Friends, it's a pleasure to be in Trivandrum again, and I thank Dr. Jyotidev and the rest of the team for the hospitality and the excellent arrangements. I'm going to talk about goal-centered innovations in basal insulins, and these are my conflicts on disclosures. So let's begin with the case. This is Mr. Rajesh. He is 48 years old. He is a lecturer, and he's thank you. He's a 48-year-old gentleman. He's a lecturer, and weight is 78. His BMI is 27. So he has need for weight management. His diabetes for 8 years. He takes 2 drinks per week. Non-smoker, irregular exerciser, and this gentleman has got an A1C of 9.7. His LDL is high, his EGFR is 68. He has microalbuminuria, and of course he is of high cardiovascular risk. He is on antihypertensive therapy, but we are here to discuss diabetes, and this gentleman is on metformin, liraglutide, empagliflozin already, and his main challenge is of course uncontrolled hyperglycemia, for which he has visited us. So if you want to look at the ideal choice of injectable therapy, whenever you need an injection, you can consider either GLP-1 or GLP-1 GIP, or then if A1C is high, you can add basal insulin. We don't know right now whether GLP-1 followed by insulin is better or insulin followed by GLP-1 is better. Probably GLP-1 and then insulin is better. But we continue to look for the best basal insulin, and in that look we had a good basal, a flat, peakless basal which is made more peakless, and with minimal glycemic variability with the newer insulins which are long-acting. And probably the best among the basal insulins is the degludec, because not just it is the most advanced, but it has the longest half-life, 25 hours, and it's also got the least variability among all the insulins, including glargine 100 and glargine U300. If you look at the PKPD of degludec, it's a flat line, and if you see the efficacy, this is a trust study where degludec actually lowered A1C significantly by about -1.8 in just 1 year. Therefore, if you look at how to transition or why we should transition, it's better to move on from glargine and to glargine U300 and the most modern, which is degludec. If you compare degludec versus glargine, degludec acts within half an hour, whereas glargine will take 2 hours to act. Degludec acts for more than 42 hours, where glargine lasts for about 22 to 24 hours. So it's faster, has a prolonged action, and if you see the action of degludec, if you draw a mental line across the top of these skyscrapers, it's a flat line, but here you see the glargine effect waning off, and in the 19 to 24 hours you actually have less glargine than desirable on board. Not that glargine is a bad insulin, but there are better insulins. And if you look at the variability, the green skyscrapers are the variability for degludec, and the red ones are for glargine, and you can see that 12 to 14 hours and 14 to 18 hours there is huge variability with insulin glargine. And this variability may increase the risk of hypoglycemia, because the problem with targeting fasting is that the more you try to reach normal fasting glucose, you will bring the postprandials into range, but the price to pay is hypoglycemia. And even if you look at the time in range, degludec offers a better time in range than glargine, so the time spent in normal glycemia is better. And if you look at hypoglycemia benefit, I think there is no doubt in this. All the trials have shown that there is very good hypoglycemia benefit, up to 86% and even up to 92% in real world studies with Degludec. So I just want to talk about this slide a little bit. On the x-axis you have the A1C, on the y-axis you have hypoglycemic events. For glargine, as you can see, if you lower the A1C, hypoglycemia risk keeps going up. But for Degludec, even if you lower the A1C, the hypoglycemia risk remains same. And you can see that, for example, if your patient reaches an A1C of 6%, you see the number of hypoglycemias with glargine is almost double that of Degludec, showing you that this is the advantage of newer insulins. You can go from point A to point B in a cycle rickshaw, an auto rickshaw, a car or a jet. The destination is the same, but how you reach that destination with more comfort, with less hypoglycemia, that is the difference the newer basal insulins make. Every insulin works, but if you want the patient to get the best insulin, and if you want to reach the target without hypoglycemia or minimal hypoglycemia, you will agree that this difference is visually and clinically significant as well, and that is the advantage of newer basal insulins. So therefore, the glargine U100 has no flexibility, whereas Degludec has a flexibility of 8 to up to 42 hours. Well, if you look at Degludec and if you compare it with glargine U300, again glargine U300 takes 2 hours to act, whereas Degludec takes just half an hour to act. Imagine an in-hospital situation where you are stopping an insulin infusion. You'll have to inject the glargine 2 hours before stopping the infusion so that glargine can begin acting. But whereas Degludec, it just has to be 15 to 30 minutes before, and Degludec will immediately act. So that's the advantage of having a quick action of an insulin, of a basal insulin. If you see the efficacy, both are efficacious, glargine and Degludec. Degludec is slightly better, but really both are efficacious. Fasting glucose control, again, pretty good control with both. Glycemic variability, if you look at Degludec, again it is uniform, whereas glargine, there is a decline in effect somewhere in the middle of the dosing, between 6 to 18 hours, there is a slight dip and then it comes up. If you look at day-to-day glycemic variability, again glargine U300 has more variability. Hypoglycemia, if you see the confirmed study, you will see that there is significantly lower hypoglycemia with Degludec than glargine, up to 30% lower hypoglycemia. Therefore, friends, even if you look at glargine U300, there is really no comparison to Degludec. Of course, cost is another matter, but efficacy-wise, if you want to go for the best, it is Degludec. You will see that the duration is, the flexibility is any time between 8 to 40 hours, whereas glargine, you have to inject it plus or minus 3 hours each day. So I think this aspect is very important when you look at what a molecule gives you. And you see the potency is also higher, and it requires, this is again the guideline. Whatever studies say, we often ask, has it made it to a guideline? And you see this is our own Indian guidelines, the RSSGI 2022 guidelines. They say that glargine U300 requires almost 20% extra dosing. So the insulin dose actually goes up with glargine, and if you look at glargine U300 being a less expensive insulin than Degludec in terms of unit price, your patient will have to inject more units, so the price wise also there is not much difference. And many things, the good control, the lack of hypoglycemia, the effective fasting, the lowering of A1C, the flexibility, the long duration of action, and also the less number of units required, which means that better is the overall experience of the injection insulin Degludec, which results in better adherence to therapy. So when you prescribe an insulin, you don't want the patient to come back and say, oh, I didn't take it, I decided to stop it and I've come back to you. Many people come back stopping insulin, stopping oral drugs. Now, why? There are many reasons for that. One is the perception of cost. Second is the need for injection. But if you put your patient on Degludec, and here you give a clear evidence here that there is a 27% lower risk of treatment discontinuation. So if you prescribe the insulin, because the control is going to be better, even if the patient has to inject it, the control is going to be better, therefore the patient is likely to take the insulin for a longer period of time. So I'd like to summarize by saying just a few points. Number one, an ideal insulin should control the blood glucose, should have minimum or no hypoglycemia, should be long acting, should have flexibility, should reduce the A1C significantly. The patient would like to take it long term, there will be less variability. If you look at all those aspects, I'm not saying that Dr.A is the most perfect insulin, but it is the best thing to happen to basal insulin since the discovery of basal insulin in the form of NPH. So you have a very flat, peakless activity profile with minimum hypoglycemia with injection Dr.A. Today, the price of Dr.A and maybe glargine 300 and other insulins have remained the same, but the paying capacity of the patients has gone up now. Given that situation, I think it is also, the economy aspect is also taken care of. Minimum variability, and what is the benefit of the variability? Minimum variability allows you to titrate the dose without hypoglycemia. So you can reach your targets without having to worry about, is the sugar going down at night? Is my patient going to get nocturnal hypoglycemia? Am I going to get a call after 1 week that I'm getting hypoglycemia? No, those things are not going to be there because you can titrate it easily in your practice. And the long duration of action allows for good flexibility. So I think that 8 to 42 hour window is useful in many ways because it allows patients to, even those who forget to take it, they forget to take it at night, you're forgiven and you can take it next day morning and then take it again that night. So these kind of things allow a lot of friendliness to the patient and therefore it adjusts to the patient's life rather than the patient having to adjust to insulin. Friends, so those are some of the advantages of the ultra long acting Dr.A and I'm sure that in your experience also it would be like that. Thank you so much for listening to me. It has been a pleasure discussing this topic with you.
Thank you so much, A.Z. Unnikrishnan sir. It was really an enlightening talk about the new basal insulins and the changes and the advantages we are getting by using such insulins in our patients. By improving, we are able to improve their quality of life. And now, once again, thank you for this wonderful session. So we have a panel discussion coming, and may I invite all the speakers. Dr. Myra Utsol sir, Hemant Thakur sir, Pramila Kalra ma'am, and Unnikrishnan sir to be on the dais, and we can have a few questions from the